Hello, I'm Nirav Shah, Senior Scholar at Stanford University. I thought I'd start by telling you a story. In 2016, the world chess champion was a computer program named Stockfish 8. That a computer is the reigning champion is no surprise. Stockfish is programmed with literally centuries of accumulated human knowledge of chess, with the standard opening books and endgame tables, and decades of computer advances since Deep Blue beat Garry Kasparov in 1997. Stockfish can examine 70 million different positions per second, and its style of play has been described as brutal, as a chess machine that is seemingly invincible. All of this changed on December 7th, 2017, with the introduction of Google's AlphaZero. Coders gave the program just one input: the rules of the game. AlphaZero uses machine learning, which is a type of artificial intelligence, and it used brute force, something called self-play reinforcement learning, to learn chess on its own. After only 9 hours of playing itself in 40 million games, AlphaZero beat Stockfish in a 100-game match, scoring 28 wins and 72 draws. AlphaZero didn't lose a single game. Compared to the centuries of accumulated human knowledge, AlphaZero started with a clean slate, then played against itself 44 million games in 9 hours to generate new insights and become the best in the world. Grandmasters have described AlphaZero's playing style as that of a superior alien species, combining the finesse of a virtuoso and the power of a machine. This was humankind's first glimpse of an awesome new kind of intelligence, demonstrating creativity, beauty, and perhaps even playfulness in how it beat the competition. AlphaZero shows us that machines can be the experts, not merely expert tools. What is frustrating about machine learning, however, is that the algorithms can't articulate what they're thinking. We don't know why they work, so we don't know if they can be trusted. AlphaZero gives every appearance of having discovered some important principles about chess, but it can't share that understanding with us. Not yet, at least. As human beings, we want more than answers. We want insight. This is going to be a source of tension in our interactions with computers from now on. I tell you this story not because you should be worried about being replaced by a Google algorithm, but because I wanted to share some of the impact of recent advances in technology. Such algorithms perform well when there are rules. They don't do nearly as well when there is imperfect information or less structure, as in medicine. So Google's self-driving cars may do all right on the streets of Mountain View, where I live, but I can guarantee you they couldn't move an inch in the chaos of a New Delhi traffic jam. And given that the reality of practice for so many internists today resembles a New Delhi traffic jam, how can we make things better and plan for the practice of internal medicine in 2030? Well, let me give you an example from how emergency medicine is changing, which I think is quite instructive on the realities for the outpatient practice of internal medicine. This past year, I had the chance to work with Adeptus, a company of about 100 freestanding emergency rooms in the Wild West in Texas and Arizona. These freestanding ERs serve as the front porch rather than the front door of the hospital, and are located in old Blockbuster Video locations in the community close to where people live. They're staffed by 4 people: a physician, a nurse, a radiology tech, and a receptionist. And with about 10 patients over 24 hours, they can turn a profit. They employ standardized workflows for the most common presenting problems. They have efficient, team-based care where the radiology tech does things like draw blood or obtain an ECG. And they have the ability to flex by increasing staffing, so each ER can scale from 8 to 80 patients. In high flu season, they've seen as many as 120 patients in 24 hours. They've broken a lot of so-called rules of traditional medicine, which, when they collectively are broken, function well in a new arrangement. Does the ER have to be part of the hospital? Do you need to wait to see an ER doc? Should we hand off patients between multiple teams and providers to match each organ to a specialist? Should ER physicians multitask across numerous patients simultaneously? In this case, in this specific care model, the answer is no to all of these questions. And the results speak for themselves. Quality outcomes exceed those in hospital-based ERs, with an average door to ECG time of 4 minutes versus 30 minutes in most hospitals. Door to CAT scan time of 11 minutes for rule-out stroke, and other metrics that only work in such an agile and lean system. Without handoffs in care from one team to the next, fewer errors occur. As you know, the most expensive asset is physician time. And by not diluting it across dozens of patients, doctors can best align clinical needs to patient preferences. By regularly iterating standardized care pathways for the most common presenting conditions, evidence-based and guideline-concordant care is provided at every site. By having physicians and nurses do joint triage on intake and joint discharge, you get 2 clinically trained staff who can catch any potential mistakes, who can reinforce patient learning, and who can co-develop a trusting relationship with each patient. The next day, the physician or nurse phones each patient within 24 hours of discharge from the ER, so patients are kept safely in the community and feedback loops are created to ensure continuous quality and service improvement. I can tell you the job satisfaction of these ER docs, many of whom fly in from other parts of the country for a week of service per month, is through the charts. The team works together closely and interdependently, enjoying and sharing a broader scope of responsibility. Care doesn't end at the door. Patient satisfaction scores also reflect the care provided. And the commitment to optimizing each component of the care model telescopes. Just as the emergency room is outsourced from the hospital, radiology in the ER is in turn outsourced, leveraging teleradiology. While early in this experiment, freestanding EDs, teleradiology, and other examples of decoupling parts of a hospital show promise in achieving AAA outcomes, with continuous learning and improved provider satisfaction built in. I'm not going to comment on my thoughts on freestanding EDs competing against ambulatory internal medicine, but I know there are several parts of the model we should look at carefully. Let me take each in turn. First, how will care change for outpatient internal medicine in 2030? You've now heard how even emergency medicine is embracing ambulatory as opposed to hospital-based care. A few examples from internal medicine may be helpful. For example, you may have heard about CityMD. These urgent care clinics started in the New York metro area and are thriving. All you have to do is surf over to the CityMD website to see how long the actual wait time is at each location, and then show up accordingly. For millennials who value convenience and access over just about everything, they aren't willing to wait the average 29 days it takes to get a primary care appointment. CityMD sees them in minutes, but then importantly, CityMD also controls where the patient goes afterwards, and owning that downstream channel is a big part of their business. Forward Medical, based in San Francisco, is another practice targeting millennials. For $149 per month, you get unlimited visits, genetic testing, heart screening, and more. Of course, there's a cool app, an iPad on check-in that shows you your playlist for the day, an Apple Store-like experience with more gadgets and flat-screen TVs in a clinic than I've seen at a Best Buy. While I don't think Forward Medical is going to replace most practices, there are elements you should understand. It's about convenience, it's about access, with all the buzzwords of upstream, sensors, personalized, real-time, platform for services, all those things simply serving as noise behind what really matters. No copays or hidden fees that make a nervous millennial feel out of control. And the hyper-connected millennial can pull out her phone and text a question in real time to a physician. Obviously, it's an important niche to be filled in Silicon Valley. Maybe you know about ChenMed. At ChenMed in Miami, their elevator pitch is that the workflow should follow complexity. An atypical patient gets an hour, and the typical patient gets 15 minutes. Now I hear you saying, in real practices, the atypical patient gets 20 minutes, the typical only 5, or maybe there's no such thing as a typical patient at all. But the top line takeaway from this practice model is that ChenMed doctors spend 189 minutes per year per patient, compared to 21 minutes on average for Medicare patients in traditional primary care practices. And other studies have shown that a common denominator for lowering total clinical costs appear to be more time spent with primary care physicians. Perhaps you've heard of Oak Street Health, started in Chicago. Their mantra is to deliver the world's best primary care to the poorest, sickest, elderly patients. They do this by being evidence-based, equitable, and accountable, while fundamentally focusing on addressing the social determinants of health in a full-risk, globally capitated model taking care of mostly dual eligibles. Their numbers for serving such a population are impressive. A 92% net promoter score. HEAT is 5-star practices, and they've cut hospital admissions by 40%. The lesson from this practice model, I think, is that knowing your patients and redefining what counts as healthcare to match what they look like makes a big difference. For Oak Street, it means covering transportation to and from the doctor's office, among other things. And so ultimately, they can make money where most doctors can't and assume risk because they know their patients so well. There are many other models worth looking at, from Aledade to One Medical, from FQHCs to Kaiser Permanente. Of the examples I gave you, some common elements include a focus on hiring the right clinicians, using analytics and data to better target patient needs, and a willingness to try new things. Yet none of the examples I gave you offer the complete answer. For example, you may think Kaiser Permanente, which has some of the best outcomes, systems for prevention and care in a fully electronic and integrated environment, might be the answer. The reality is that it takes about 3 years for a newly hired physician to practice the way his or her more seasoned peers do at Kaiser. So is there a secret sauce for high quality, low cost outpatient internal medicine practice? We know from work done by Arnie Milstein that high value primary care practices share certain characteristics. After ranking over 50,000 practices on quality and cost, his research team used a positive deviance approach to identify the consistent highest performers, those with simultaneously low cost and high quality, and compared those best performers to average practices. What they found will be of no surprise to you. They found that the best performers create deeper patient relationships by extended hours and thoughtfully using tools like email. They practice what he calls conscientious conservation of resources by adherence to guidelines and leveraging clinical decision support, aggressive closing of care gaps, adjusting care intensity every morning using team huddles to match patient needs to services. They practice informed shared decision-making and are good at advanced care planning, which only works because the trust and the access and other components also work. They treat patient complaints like gold, learning and improving constantly. They practice with a wider scope of responsibility, especially where they had more risk. So they did more of the basic things like stress tests in-house. When a referral was needed, they would coordinate care and did so thoughtfully to the specialist who also practiced with an attitude of conscientious conservation. They upshifted staff roles and used standing orders. They used shared workspaces. They kept overhead low with modest offices. Finally, regardless of how they were paid by health plans, they were very thoughtful about how they paid themselves. For example, sharing pay-for-performance bonuses with the frontline staff. Now, you may have noticed, until now, I haven't really talked much about technology, which you might have thought would be the focus of remarks on healthcare in 2030. The reality is, I can't say where we'll be. 20 years ago, they said electronic health records would be the silver bullet. And look where we are today, with date night being replaced by date night with the electronic health record. And the best indicator of physician burnout is if you need pajama time in the evening to sign off on diabetic shoes and hearing aid batteries. 5 years ago, they said artificial intelligence would render every radiologist, dermatologist, and pathologist obsolete. That hasn't happened. So from inflated expectations, we've entered the Gartner hype cycle stage of the trough of disillusionment. Still, there's hope. I think by 2030, what we're seeing with human scribes today might be replicated by an Alexa or Siri that can listen in the background and simultaneously and instantly write up notes for clinical care, notes tailored for patients, and notes for billing purposes. Alexa will create referrals on the fly and create safety nets for prevention and other evidence-based care. But the role of the MD will be important, especially in managing the complexity that is left behind after the easy stuff is addressed by technology. So while over the past few decades we've further specialized, in the era to come, complexity will demand a God's eye view. There will be a more urgent need than ever before for the higher level performer who can reconcile patient preferences with clinical reality, who can reconcile caregiver capacity with who's paying for what, and who can understand what's right for the patient in ways that no number of super specialized med techs, phlebotomists, and other carve-outs of the care team or algorithm can provide. In Silicon Valley, there's an urgent need for such high-level performers. The example I'll give you is for a newly minted PhD in data science. These kids earn a base salary of $650,000 fresh out of Stanford. I don't know that internists will get out of medical school that way, but already for the past 4 years, Kaiser has paid general internists more than many specialists. And with the continued changes in the workforce, educators suggest that the next generation of students should focus on the 4 C's: critical thinking, communication, collaboration, creativity. I think these are already our superpowers as practicing internists. Not an hour goes by without our using advanced skills in critical thinking, communication, collaboration, and creativity. We can further help internists build collaborations with non-traditional partners. We can redefine what counts as healthcare with things like addressing the social determinants of health. Maybe we should define ourselves as a new provider class with internists trained in change management, improvement science, team-based care, eliciting patient-reported outcome measures, and driving good outcomes. Google's AlphaZero may have helped create a new philosophy of chess. It's up to us to imagine a new practice of medicine.